Good evening.
Have you started the class?
Not yet. We are waiting for you and Dr. Sarkar.
Dr. Sarkar will be joining. He's still in the OT, so he may be a little late. So I am just waiting another 3-4 minutes before the official start of this today's class. Very important topic of cancer, prostate, and this will be discussed by two very competent teachers of very competent teachers of this state. Competent teacher of this state to teach you, and I don't think either in theory or in practical you can escape discussion on this topic. And today's program has been proposed in such a way, today and tomorrow we'll cover mostly the point of discussion which are necessary for the examination will be discussed. So with this short introduction, I have to say that today's faculty is one of the best faculty who are very good speakers, not only speakers, they're excellent teachers too. With this introduction, I hand it over to today's moderator, Dr. R.K. Gopalakrishna, to start the session, and which will be supported by very able another teacher, Dr. Himadri Prathak from Calcutta, Vivekananda Institute of Institute. And I request Dr. Gopal to conduct the session the way he wants to. Thank you very much.
Thank you, Ranjendra. Thank you. Hello, good evening, Himadri.
Good evening, Gopal. Good evening. Nice to connect.
Connect, yes.
Yeah.
We should have been someplace else, but
that's all right. That's okay. I think we could get started with the
yes,
presentations.
Good evening, Professor Tiwari.
Good evening. Good evening,
good evening, sir. Good evening.
Okay, so the first topic of the day by Dr. Priyanku Pratik Sharma, that is management of localized prostate cancer. This is a 20-minute presentation, so if you may either take the full 20 minutes or if you present shorter than that, that's also good. Then we will have time for question and answers. Okay, Priyanku, over to you. You may screen share.
Yes. So is my screen visible, sir?
Yes, it is. Please go ahead.
So good evening, everyone, respected teachers. Today I'm going to present my topic, management of localized carcinoma prostate. So in the background of this disease, prostate cancer is the most common non-cutaneous cancer, and it is hereby also the second leading cause of death in men from cancer. Since this disease is prevalent worldwide and exhibits a wide spectrum of aggressiveness, there have been different methods for approach to its treatment deployed, and some preferred methods for treatment are also under trial, and some of them are controversial. It is seen that the prevalence of prostate cancer increases strikingly with age, and there are present evidence of microscopic foci of cancer seen in 1/4 to 1/3 of men. And gradually with the advance of age, it increases up to more than 3/4 in the 9th decade. So 16% of men diagnosed with prostate cancer ultimately are seen to die of it, and it is the cause of death in about 3% of male population. 90% of the cases are being detected in a clinically localized state. So it is seen that majority of the cases are being detected in clinically localized state, and that is why the management approach in this clinically localized state is very important in the future and the ultimate prognosis of this disease. So what are management of prostate carcinoma is a stage-wise or risk assessment approach, and it is based on its particular situation of the disease. We know that prostate cancer can be either localized prostate, it can be locally advanced, it can be a recurrence in form of biochemical recurrence following a primary therapy. Then finally, it can be metastatic carcinoma and it can be castrate resistant. So in this class, basically, we have to discuss localized prostate carcinoma. So just basically, how do you stage regarding the staging and prognostication of this disease? There are certain goals of staging prostate cancer, and it is to predict the prognosis and also to rationally derive the therapy on the basis of the predicted extent of disease. Commonly, it is a TNM staging that we use for the treatment approach. Some pre-treatment parameters are used for predicting the tumor extent, like serum PSA. Just to mention that PSA level and tumor extent, it helps us to get an idea of the percentage of organ confinement. If it is less than 4, then we can envisage that 80% might be organ confined. If it ranges from 4 to 10, then there is chance of 66%. And if it is more than 10, then there is on less than 50% organ confinement. Similarly, lymph node involvement can also be predicted. If it is more than 20 nanogram, then 25% of cases will have lymph node involvement, while more than 50 will have 75%. In case of DRE, positive DRE will also give us a high risk idea of the presence of high grade tumor. Then Gleason score and imaging are the further things that can help to predict the tumor extent. So this is the TNM staging. So for our concern, it is T1 and T2 tumors, which comprises comprises our study, that is localized prostate carcinoma. Sorry. So T1 comprises T1A, B, and C, where we know that when in histological finding, T1A and 1B are actually post-prostatectomy specimen findings, where less than 5% will give T1A and more than 5% involvement will give T1B, whereas T1C is that identified by needle biopsy. On the other hand, T2 is comprises tumor that is palpable and confined within the prostate. They are also subclassified in the 7th edition, but however in the 8th AJCC classification, it has been converted into a single group, that is tumor that is just palpable and confined within the prostate. So basically T1 and T2 is for our reference. So localized prostate cancer, it is a slow growing tumor which shows median time to metastasis post radical prostatectomy of 8 years, and median time to death from metastasis is 5 years. It is based on risk group stratification, which we will study shortly. The tumor characterization for prediction of pathological stage comprise of some nomograms or predicting factors. Basic evaluation is by the routine serum PSA and PRAS guided biopsy, and need for additional imaging in terms of mostly MP MRI. However, imaging may not be indicated if the preliminary findings suggest a Gleason score of less than 7, PSA less than 10, and biopsy is not suggestive of aggressive cancer. So regarding the risk stratification, why risk stratification is important? Because nowadays in relation to prostate cancer, it is based on the different risk stratification groups that we suggest or that approach to the different treatment modalities. So there are some stratification groupings like PCPT trial based calculator, which is dependent on race, age, PSA level, family history, DRE findings, and prior post-prostate biopsy findings. This is a commonly used Partin tables, which predicts the involvement of lymph node status, extra prostatic extent, seminal vesicle invasion. There we use some clinical variables to predict the stage of tumor, whether it is organ confined or there is nodal involvement. These probability tables are based on basically 3 parameters: it's preoperative clinical stage, serum PSA level, and Gleason sum. Then we have some other scores and nomograms as well: the Capra score, MSK-CC nomogram, and post pre-treatment MSK-CC nomogram, and post-treatment MSK-CC nomogram. So these are the different factors that are used in the nomogram. I will not describe in details. And some other scores like Briganti score, Rhodes formula, and Cutton's nomogram for indolent CA prostate. But most importantly, among all these stratification groups is the DMICO, and or the more commonly advocated EAU risk groups for prostate cancer stratification. This grouping is important where both localized and locally advanced carcinoma are classified into these risk groups. So we are concerned about localized prostate carcinoma, where we divide these risk groups into low risk, intermediate risk, and high risk based on 3 simple factors in each group. If the PSA is less than 10, Gleason score or is less than 7, that is up to 6, or ISUP grade is 1, and clinical T staging it is up to clinically T1 to 2A. Then we have intermediate risks. So from the previous group, from low risk, we have, it was less than 10, here we have 10 to 20. Gleason score was less than 7, here we have Gleason score 7, which comprises ISUP grade 2 or 3, and clinical stage is T2B. Whereas in the high risk group, we have a PSA of more than 20, Gleason score more than 7, that is ISUP grade 4 and 4 or 5, and it is clinical TC, T2C. So basic evaluation process comprises of undergoing the PSA scoring, then MP MRI with trust biopsy prostate, and requirement of a preliminary pre-operative or pre-treatment approach CT or bone scan for documentation purpose as well as for future references. The AUA and NCCN guidelines recommended avoiding a routine bone scan in men with low risk prostate cancer who have a PSA below 20 and a Gleason score of 6 or less, unless there is a suggestion of bony involvement. Now the EU guidelines, according to the risk based approach, they say that low risk localized prostate carcinoma, you do not need to use additional imaging for staging purposes. In case of intermediate risk with predominantly Gleason pattern 4 or ISUP more than equal to 3, we should use prostate MP MRI setting for local staging and a CT bone scan for metastatic screening purpose. And in case of high risk prostate carcinoma, we have to definitely use prostate MP MRI and a metastatic screening, including at least a cross-sectional abdominopelvic imaging and a bone scan. So what are the different treatment modalities available for prostate cancer and what we are going to use in localized prostate carcinoma? So in the different treatment modalities that are available are the radical prostatectomy and radiotherapy, which have been deemed as established treatments. And then there are some other modalities of treatments in terms of active monitoring, watchful waiting, hormonal therapy, and some focal treatment methods like cryoablation, radiofrequency ablation, and high intensity focused ultrasound. So what is active surveillance? So it is a standard alternative to curative intervention for some select group of patients who are diagnosed through screening purposes with PSA based screening, in whom it is seen that the natural history of the disease may be prolonged. It can be defined as continuous active monitoring of the disease with serial imaging PSA estimation in a patient suitable for curative treatment. It is usually ideal for curable low risk patients which are suitable for radical treatment, but these patients wish to avoid treatment related complications. So there are criteria for patient selection in this group. We have the Epstein criteria, where we use it for insignificant low risk tumors, which comprise the most popular method used for patient selection. In this criteria, insignificant tumors are predicted by clinical Gleason pattern 3 or less, clinical stage T1C, and either of these two situations where PSA density will be 0.1 nanogram per ml per gram or less, 2 or few biopsy course, and no course with greater than 50% involvement. And the other scenario whereby there is the same thing, a clinical Gleason pattern 3 or less and clinical stage T1C, it should be cancer smaller than 3 mm on only one biopsy core. That is important. And PSA density less than 0.15 nanogram per ml per gram. NCCN guidelines say that the option of active surveillance for low risk disease defined as PSA level 10 or less, clinical stage 2A or less, and Gleason grade 3+3 or less. It is indolent cancer defined as being organ confined, less than 0.5 ml tumor volume without poorly differentiated elements. Early confirmatory biopsy will serve to limit the risk of clinical undergrading of tumors, which can result from sampling on a typical 12-core biopsy. Therefore, they advocate this for repeat biopsy within 3 to 6 months of diagnosis. Now, what are the indications to discontinue active surveillance and how should we monitor active surveillance? Whenever there is an increased amount of cancer on the, for example, if we get more than 2 biopsy cores or more than 50% on a biopsy core. Similarly, if we get an increase in the Gleason sum with a pattern of 4 or 5, rapidly rising PSA and patient anxiety, another important factor to consider. So in this situation, we have to discontinue active surveillance and go for a definitive modality, mostly a surgical approach like radical prostatectomy. And how do we do the monitoring of active surveillance? There is actually no recommended schedule, but they said that confirmatory biopsy has to be done within 3 to 6 to 12 months, repeat biopsy annually or every 3 to 4 years, and monitoring of PSA half yearly, along with PSA velocity and PSA density. Coming to watchful waiting, it actually refers to monitoring of the patient until he develops metastasis, and that will eventually require palliative treatment. Now, this option is only for men with a limited lifespan or life probability, that is less than 10 to 5. So, in contrast to active surveillance, where we prefer it for patients who have a long-term probability for life longevity, watchful waiting is for patients with a limited longevity. Also, it includes patients who are unfit or with significant comorbidities. The aim of this purpose is to avoid treatment, definitive or invasive treatment. The intent will be palliative, to give him the patient an eventual palliative treatment. No specified protocols are available. And evidence from the pivot study is says that compared with radical prostatectomy, no overall cancer survival evidence between the two arms has been seen. Now, coming to curative treatment in terms of radical prostatectomy, which is the main mode of treatment, and it still remains the gold standard for localized prostate cancer. So we see that most of the prostate cancer patients have some similar priorities. Obviously, they want to survive, they live long enough like a normal contemporary. Secondly, they want to remain continent as per their urine flow results. And the third, obviously, patients also wish to preserve their potency. So these three factors can together known as the trifecta or a constellation of favorable outcomes is important while considering curative treatment. Basically, the procedure involves complete removal of the prostate gland and seminal vesicles and usually includes a modified pelvic lymph node dissection. Pelvic lymphadenectomy is optional in patients at low risk for lymph node metastasis. The key to preserving urinary continence is to perform a meticulous dissection, avoiding injury to the external urinary sphincter. The ideal scenario for this situation, it is for radical prostatectomy, is a healthy patient free of comorbidities. He should have a life expectancy of at least 10 years. The tumor should be deemed to be biologically significant and completely resectable. Usually, the accepted upper age limit for radical prostatectomy is 76 years. Patients with a low probability of resectabilities or a short life expectancy should not be advised to have cis surgery. On the other hand, some hormonal therapy like neoadjuvant therapy, it is seen that they do not, which have been in the underlying process for as a part of the treatment for prostate cancer, doesn't seem to enhance the resectability, nor it increases. Also, it increases the difficulty of performing a nerve-sparing surgery. Neoadjuvant chemotherapy does not produce pathologically complete response. So that is important. So regarding the surgical approaches, we have a perineal radical prostatectomy approach where there is evidence of less blood loss and a shorter operative time than the retropubic approach. The basic disadvantages are it does not provide access for a pelvic lymph node dissection. It is more difficult to repair the cavernous nerve, and there is higher rate of rectal injury and rare postoperative fecal incontinence that does not occur commonly with other approaches. Then we have a retropubic approach, which is usually popular because of the surgeon's familiarity with the surgical anatomy. There is lower, in contrast to the perineal approach, there is lower risk for rectal injury and postoperative fecal incontinence. The most important aspect is the wide exposure, which is very necessary in any kind of open surgery, and ready access provided for pelvic lymphadenectomy. That is the most important part and important highlight of doing a retropubic approach. The prostate excision with preservation of the neurovascular bundles and lower risk of cancer at the surgical margins is also important to notice in retrophobic approach. Then we have a laparoscopic approach, counting method of performing heretical prostatectomy, but nevertheless, laparoscopy is always the one of the best methods for any kind of surgery if we have the sufficient set of skill. Obviously, it is very useful because of its association with significantly less bleeding, better visualization, less post-operative pain, shorter convalescence than the standard open approach. Also, it is seen that the laparoscopic approach can be done through a transperitoneal or extraperitoneal approach. Coming to the robotic approach, is the most advanced mode of modality here. It became popular because of better technical ease for the surgeon, because of, as we know, because of the improved three-dimensional orientation, as well as the degree of freedom provided by robotic approach. It is especially for tying sutures and performing the vesico-urethral anastomosis, lower blood loss in all respects as in all laparoscopic options. The availability of this 3D visualization and enhanced dexterity are, as I've already said, its main advantage over standard laparoscopic techniques. The complications of the radical prostatectomy, I've just shortened it, not described in details. The main complications are impotence. Incontinence impotence is seen in 40 to 60% of the cases. Incontinence can be seen early in 50% of the cases, and late incontinence in 5 to 10. Anastomotic stricture in 10% cases. Infection, bleeding, chest complications in 5 to 10% of the cases. Rectal injury in 5% of the cases, and the most dreaded mortality in 1.5% of the cases. Nerve sparing surgery is a vital option, but we have to see that there is no extensive cancer in the biopsy specimens. There is no palpable extraprostatic tumor extension. Serum PSA should be below 10 nanogram. Gleason score less than 7. There should be decent or good preoperative erectile function, and then patients should desire a sexual relationship later on post surgery. He should not be having any medical conditions that can adversely affect his erection. So if we find these features, then it provides a scenario where we should not go for nerve sparing surgery. Coming to the other important modality of treatment in localized prostate cancer is radiotherapy. As we all know, external beam radiation therapy, which is the primary standard of care, amongst which intensity modulated radiotherapy with image along with image guidance is the present standard of care and the most accurate methods to give the maximum efficiency out of this therapy with minimal damage to the normal prostatic tissue or the normal surrounding tissues. We know that external beam radiotherapy uses gamma radiation beams directed at the prostate and surrounding tissues also through multiple fields. As a part of the relative contraindication, we should know that a prior TURP is a relative contraindication because it can lead to incontinence. Contraindication is inflammatory bowel, presence of inflammatory bowel disease, which can in which scenario we always or we should be taking a gastroenterologist's opinion prior to going for those particular therapy. The side effects of external beam radiation therapy includes 5 to 10% persistent irritable bowel symptoms, and in 10 to 15% of cases intermittent rectal bleeding. Approximately half of the patients will eventually become impotent. Coming to brachytherapy, this is primarily used for the treatment of patients with clinically localized prostate cancer. It is done with either iodine 125 or palladium 103 and will deliver around 125 to 145 gray of radiation to the prostate. However, it should not be used in larger prostates with exceeds 60 grams of weight and those with higher Gleason scores. So basically, to summarize the indications, we use low dose radiation monotherapy for low risk disease, which comprise test T1B to T2A, Gleason score 6 or IOCP 1 with less than 50% core, and IOCP if it is 2, then it should be less than 33% cores involved. Then the other factors, initial PSA should be less than or equal to 10, and prostate volume should be less than 50 or 60 grams as I have said. IPSS should be up to 12, and another important thing is to note pre-procedurally we have to note the quality of urine flow in the patient, and if it is very poor, we should not opt for it. That is why the IPSS should be up to 12, and Qmax should be ideally more than 15 ml per second. Prostate brachytherapy can be delivered as monotherapy for low risk prostate cancer or in conjunction with external beam radiotherapy with or without androgen deprivation therapy for when there is intermediate risk and high risk prostate cancer. Coming to hypofractionation or stereotactic body therapy, which are the other options. Hypofractionation is basically smaller fractions with, that is the smaller, we give less number of fractions, and that is why per fraction the dose will be relatively higher. The tissues here, it is seen that the tissues with slow proliferation will show repair between the fractions, and hence the in the later fraction that it will show the mechanism of action of that of desired importance. It is seen that a increased patient convenience is seen when we opt for a hypofractionation. There is more compliance from the patient point of view. Also, it leads to lower cost. Moderate, we use 2.3 to 4 gray, and extreme we use 5 to 10 gray per fraction, whereas the normal is usually lesser dose, that is 1.8 to 2 gray per fraction. Stereotactic body radiotherapy, which comprises cyberknife system. It is also a mega voltage LINAC system mounted on robotic arm. So these are the other methods that are used as part of radiotherapy in prostate malignancy. Coming to some aspects of focal therapy. So
you have 1 minute left.
Yes, sir. I'm just completing it. We have cryotherapy, which is indicated in localized non-metastatic or low risk carcinoma prostate. Smaller gland less than 40 cc, no prior TURP with more than 10-year expected survival, and focal ablation up to Gleason 3+4, PSA 10, and CT2A, and PSA velocity more than 2. So mechanism of action, basically it is a freezing system with ice crystal with regular thawing and repeated thawing process leading to reperfusion injury by oxidative free radicals. There is inducing of coagulative necrosis at the center and apoptosis at the periphery. So in short, this is the mechanism and technique. We use a 18 French Foley's with 60 ml saline in balloon. We inject saline into the denonvillers, which have to displace the rectum, and finally we use the probes to proceed with the technique. The perineal placement of probes is done using brachytherapy template. Finally, we remove the catheter and cystoscopy is done to see if the urethra is safe enough, followed by warming the catheter for continuous warm saline. It is usually done for gland. If the glands are seen to be larger than 40 cc, we have to use more number of probes. Peripheral temperature, the thermocouple should be limited. Double freeze-thaw cycle should be followed by rectal examination to confirm that there are no ice crystals, and a minimum temperature of -400 Celsius and a double freeze-thaw cycle with urethral warming is recommended for cryotherapy. Complications are erectile dysfunction, urethral sloughing. Yes, sir. Sir, just to conclude, sir, I have one slide.
Okay.
High intensity focus ultrasound is also the other mode of modality for focus treatment. So to summarize the compilation of management, we can see that in case of low risk disease, we opt for watchful waiting. We can go for active surveillance when patients are suitable for curative treatment. Perform an MP-MRI before that. During in confirmative biopsy, we should include systematic and targeted biopsies, and follow up routinely with yearly DRE 3 to 4 monthly PSA and repeated biopsy 3 to 5 years. Radical prostatectomy is the gold standard of treatment. It is the best alternative in well-informed patients, and nerve sparing should be decided intraoperatively. Regarding radiation therapy, that is also considered as an established option in low-risk disease. Focal therapy is used only in clinical settings. Whereas in intermediate risk disease, we do a radical prostatectomy if life
I think I need to stop you here
more than 10
because
years.
we are running out of time. Okay.
Yes.
Okay. I'd ask the teachers if you have any questions to Priyanku at this stage. He has spoken about management of localized carcinoma prostate. Well, then if there are no questions, I'll just ask you one question before we move on. If you were a consultant and you had a patient with an early localized carcinoma prostate, how will you counsel him in favor of radical prostatectomy, you being a urologist?
So if he has got a decent life expectancy, so as we have seen in one of the criteria that patient's willingness for survival, So that is the most important part
No,
in the
I mean,
counseling process.
between the various options that you have presented, if you have to counsel him for radical prostatectomy, how will you counsel him in your favor? What are the advantages of radical prostatectomy over the other options?
Sir, it is the best modality as part of curative treatment, sir. So in the other option, there is always a chance for recurrence. There is inactive surveillance. Also, there is chance of going for metastatic, significant metastasis because of the seedling process. And radiotherapy, sir, there are complications like incontinence issues, flow rates we have to consider, and as well as the quality of life post radiotherapy. So and also there is chance of recurrence, including biochemical recurrence, which is quite less in case of radical prostatectomy, which is a definitive curative therapy, sir. So that is how we have to counsel the patients. Or
Okay, Dr.
We have
Anand, yes.
Yes, sir.
Dr. Anand, do you have anything else to add if you have to counsel a patient in favor of radical prostatectomy?
Sir, in a patient, a radical prostatectomy is always, as he told, it is giving us, more importantly, the exact the exact staging. We'll be, and thereafter we'll be guiding the post-radical prostatectomy, the
Management. Okay.
Yes.
What else? He said the second was avoiding post-radiation complications.
So most importantly, the complications like the GU the genitourinary toxicity and the gastrointestinal toxicity has been found to be much more.
Any
Yes.
other advantage?
Anything else? Yeah.
Sir, accurate staging, I've just told.
We have already said.
Uh,
And the third advantage, if a patient has obstructive urinary symptoms, a radical prostate will relieve those at the same time. Okay.
Okay.
So if no other questions, let's move to the next speaker. Anand, it's you.
Yes, sir.
You are going to speak on management of biochemical recurrence following radical prostatectomy. Over to you,
Yes.
Anand.
Priyanko has to stop sharing her screen. The Priyanko has to stop sharing her. Sir, are the slides visible, sir?
Yes, they are visible. We are already 5 minutes over time, so I'd suggest you to stick to time.
So good evening, everyone, my teachers and my colleagues. Today, I'm going to speak on the management strategies of biochemical recurrence post the radical prostatectomy. I'm Dr. Anand Biyani from Arjikar Medical College and Hospital. So radical prostatectomy has been, as already told, undergoing the curative, it is one of the most important local therapies for management of the for management of the prostatic cancers, but still we are finding around 20 to 45% of the patients who experience biochemical recurrence at some point post the therapy. These biochemical recurrence are having a heterogeneous nature, and so its management strategies have been varied, and they have been further complicated by the advances that have been there within this field in the last 2 decades. What is emphasized here is that what is emphasized here is that the treatment recommendations for these patients should always be after the discussion with the multidisciplinary team. What we find sometimes post-radical prostatectomy, the patient continues to have detectable PSA, although that is not progressively rising and maintaining a low plateau levels. The reason being 3 conditions. First is because of the residual benign disease that is left within the prostatic bed, or it may be because
Anand,
of
1 minute.
certain cells of the non-prostatic
Please stop,
origin,
Anand,
which
1
continue
minute.
to produce the PSA at a very low levels, or
Anand,
it can
1
be
minute,
because
please.
of a residual low-grade prostate cancers.
Anand, 1 minute, please.
Yes, sir.
1 minute.
Can you
Hey,
please
Ruma,
mute everyone?
please mute everyone. Please mute everyone. We cannot hear the speaker. Please mute everybody, excepting the speaker and the moderator. Please.
Carry
Anand,
on,
you can
Anand.
start.
So as I was just saying that there are certain patients which we see that even after the prostatectomy, they continue to show a detectable PSA level, although that may be of a very low value and that is not progressively rising. The main three reasons have been identified. First is basically a residual benign disease which is left in within the prostatic bed, or it may be because of certain cells of the non-prostatic origin which are producing the PSA at a very low values, or it may be because of a residual low-grade prostate cancers which are destined to have an indolent course that leads to the elevation in the PSA. So as we can see from this figure, the patients who are having a radical prostatectomy with post-radical surgery a rising PSA, it may be because of either a local recurrence that has taken place in within the prostatic bed, or it may be because of an occult distant metastasis, either to the non-regional lymph nodes or to the bones, or systemic metastasis, or it is a combination of both. So why is this biochemical recurrence important? There are certain questions we need the answers to, and in the following slide, we'll be finding them. What is the best definition for the biochemical recurrence? What does it actually predict? How it is the features which are driving the biochemical recurrence? What are the basic good imagings that will be helping us to best characterize the biochemical recurrence? And what are the management strategies that will enhance to improve its diagnostics? So first, coming to the definition, there have been various studies which are going on defining the biochemical recurrence, but it was finally the AUA who came to the standardized definition of keeping a cut point of more than 0.2 nanograms per ml with a second confirmatory values of more than 0.2. It is seen that the PSA becomes almost undetectable levels post-radical prostatectomy around 3 to 4 weeks after the surgery. Morgan et al. In 2014 found that persistently detectable or subsequently rising serum PSA levels after the radical prostatectomy is either indicative of a recurrence or it is indicative of a residual prostate cancer. Memorial Sloan Kettering Cancer Center demonstrated that values of more than 0.4 nanograms per ml is increasing the probability of metastatic progression post-surgery. The EAU guidelines are also they are also in consideration with the AUA guidelines, and also they define that the PSA values of more than 0.2 nanograms per ml as residual or recurrent disease, and if a value of PSA is more than 0.4 nanograms per ml, there is always a high chances of progression to metastasis. There has been an advent of ultra-sensitive PSA measurements which have come into the picture, but still now we are not included. But still now we have not included the ultra-sensitive PSA or the super-sensitive PSA in within the AUA guidelines to define the BCR. Although there was a study that was done which showed that PSA with the nadir values of more than 0.008 were able to have values of higher probability of BCR. So what is the natural history of biochemical recurrence? It actually has been seen that the biochemical, once the PSA recurrence has been diagnosed, it is important to determine whether the recurrence is coming from the local or from the distant sites. And it is the impact of biochemical recurrence, which is the basic impact of the biochemical recurrence is that they are at an increase in the risk of developing metastasis, the prostate cancer specific, and also the overall mortality. So basically, as I told, the outcomes associated with the significant prognostic factors are that they are leading to the increase in the chance of distant metastatic recurrence, which is particularly defined by the presence of positive surgical margins, high recurrent radical prostatectomy specimen, pathological IOSP grade, high staging categories, and a short PSA doubling times. The prostate cancer specific mortality as well as the overall mortality are also predicted by the biochemical recurrence, and both are shown to have a high specimen pathological IOSP grade with a short interval to the biochemical failures. Although the prostate cancer specific mortality has been shown to have short PSA doubling times. So the EAU has actually risk stratified the patients according to the patients as low risk and as a high risk for the biochemical recurrence. Any patient who is having a PSA doubling time of more than 1 year or a pathological IOSP grade of less than 4 following the radical prostatectomy are defined as low risk for the EAU, and thereafter high risk are those which are having a PSA doubling time of less than 1 year with a IOSP grade of more than 4 to 5. There has been various nomograms which are available, which are helping us to predict the biochemical recurrence post the radical prostatectomy, which are available online. These are the various ones, as we can see. As pre-treatment, it is the MSKCC and the CAPRA score, and the post-treatment also is MSKCC. The point here adding is that the CAPRA score has actually added a variant which is known as a CAPRA S score, which is a post-treatment protocol wherein we have taken into account the seminal vesicle invasion, the surgical margin status, along with the EPE as well as the lymphovascular invasions into account. There has been a role of positive margins in the biochemical recurrence. As has been seen that patients who are having a positive margins with the T2 disease on histopathology, they have increased in the chances of 12% biochemical recurrences. But the point here, to make here is that even at a higher values of, even at a higher stage like T3A, if they are having negative margins, they will have a lower risk of biochemical recurrence with respect to the T2, which is the lower stage, if they are having positive margins. A margin which is greater than more than 1 mm has been statistically significant increase for the biochemical failure. So how are you going to diagnose the biochemical recurrence? The conventional methods like the CT scan and the bone scans, they have not been found to be very sensitive to diagnose the biochemical recurrence at a lower values of PSA. But although there has been a reasonable sensitivity of the TRUS, which is to find the recurrence, especially at values which is more than 2 nanograms per ml, but they are also having a lower sensitivity of less than 50% if the values of PSA is less than 0.5 nanograms per ml. So what has come across as a new era is going to be the PET CT. But we need to understand that the PET CT, the formal FDG PET scans, they are not going to be so sensitive for the diagnosis, as the glucose uptake is going to be less within the prostate cancers. So they will not be able to detect the recurrences, but there are certain new drugs, there are certain new radio tracers like choline acetate, which has come across. Choline is serving as a precursor for phosphatidyl's, and they are accumulating in the proliferating cell membranes, allowing for detection of the radio-labeled choline analogs. There are two most commonly radio tracers which are available. One is the 11 carbon choline and the other is the 18 fluorocholine. Although they are having a lower sensitivity, but they are having a very high specificity of almost around 97%. It is the NCCN guidelines which are suggesting that a minimum threshold of 2 nanograms per ml is going to be required for the choline PET CT to detect the biochemical recurrence. As we can see, the choline PET CT is the detection rate is actually depending upon the PSA levels. And whenever there is an increase within the PSA level, there is a better detection rate that we can see with the choline PET CT scans. With more than 3 nanograms per ml, almost having a detection rate of almost around 73%. There is fluvi-clovine PET CT scans. These are the ones which are 18 fluorofluvi-clovine. They are having a slightly higher sensitivity than the choline PET CT in detecting the site of relapse. Although it has been seen that their sensitivity is also dependent upon the PSA values, with sensitivity likely to be inferior than 50% when the PSA values are less than 1 nanograms. The studies to date suggest that the most optimal threshold levels for the fluvi-choline PET imaging is at 2 nanograms, although there are some studies which are also suggesting that they may show a higher positivity rate if the patients are having a PSA values of between 1 to 2. What is the new technique that has come across, which is most sensitive actually for detecting the BCR? It is the PSMA PET scans. What is PSMA? PSMA is actually a transmembrane protein located on the short arm of chromosome number 12, which is normally expressed within the prostatic epithelium. And within the neoplastic transformation, they have an increased intensity and they are normally translocated from the apical membrane to the luminal surface of the ducts. So this is basically the PSMA, which is the ideal target for molecular imaging and have been overexpressed almost 100 to 1000 folds within the cell membranes of the prostate cancer cells. Their expressions are increasing according to the stage and according to the grade of the tumor, with increase in the expressions, particularly for the advanced stage prostatic cancers and for the castration resistant prostatic cancers. So as we can see, it was a study that was done by Eliver et al., who showed that patients who were almost 248 patients with a mean PSA of 1.99, they were having almost 90% patients which were having suspicious lesions detected by the gallium-68 PSMA PET scans. Again, what we can find from this particular chart is that with the increase within the PSA levels, there is the increase in the detection rates. So its detection rate is also depending upon the PSA levels. The most important inference that we draw from all this from this chart is that the gallium 68 PSMA PET scan has been found to be the most sensitive test to detect the BCR even at the lowest values of the PSA, which is less than 1 nanograms per deciliters. So how to assess the local recurrences? It has been seen that the sensitivity of anastomotic biopsy has been found to be low, which is especially for the PSA of less than 1 nanograms. So we are not depending upon the histopathology, and we are not waiting for its report, and we just can start with the salvage radiotherapy even without the histopathology reports. It is the MRI which is able to detect the local recurrences in the prostatic beds with a sensitivity, but its sensitivity is particularly controversial when the PSA levels are less than 0.5. The choline PET CT has been found to be less sensitive than the MRI with a PSA level when it is going to be less than 1. The point here to emphasize is that the PSMA PET scans have shown that substantial level of recurrences after radical prostatectomy were outside the prostatic fossa, even at the low PSA values. And it is the combined study of the gallium PSMA PET and MRI. They have always an improved level of detection of local recurrences as compared to the gallium PSMA PET CT. The role of MRI, as has been seen.
Please hold on for a minute. Can the administrator
Hey,
please
who has
Dhananjay
put
Kumar?
on this music? Please stop it.
Hello.
Yeah, that's better. Thank you.
So what's the role of MRI in detection of the biochemical recurrence? It has been seen that the dynamic contrast enhanced modalities have been found to be most effective in detecting the biochemical recurrence, with almost sensitivities reaching to 100% with respect to the diffusion weighted images and the MR spectroscopy. The highest sensitivity specificity has been seen particularly with the DCE and T2 when they are found to be used as combinations. So what is the EAU guidelines for imaging? They say that you have to perform a PSA PET scan if a patient is having a PSA values of more than 0.2, and if the results will influence subsequent treatment decisions, although it is having a weak recommendations. In case of PSMA PET scan which is not available and the PSAs are more than 1, we can perform as a fluvicholine PET CT or a choline PET CT. So as we have come with the advancements of more understanding of prostate cancer at the molecular level, certain tissue-based markers and genomic testings had come up, particularly the Decipher testings. This is basically a 22 RNA biomarker with multiple biological pathways and has been related to the development and progression of the prostate cancers. The high genomic classifiers score is always associated with a high level of metastasis. As we can see that the Decipher is able to predict, first of all, is the high-grade disease. It also helps us to predict the 5-year metastasis and the 10-year prostate cancer specific mortality. And it has been seen that patients who are having a low-risk Decipher biopsy have a favorable prognosis and may be suitable candidates for active surveillance and have an excellent outcome with a local therapy alone. But those patients who are having a high-risk Decipher biopsy, they have an unfavorable prognosis and they need more intensified studies. So Decipher test is shown in 3 values. One is high risk, one is average, and the other is low risk. The ones who are having a high risk Decipher tests are at an increased in the risk of a high-grade disease and increased chances of the 5-year metastasis and a high risk of mortality as well. So these are not going to be the suitable candidates for active surveillance, and they will be requiring much more intensified multimodal therapy, which helps us to guide the management as well. For example, if a patient is having a genomic classifier of low risk, then we may observe these patients post the surgery with the PSA monitoring, and when it has become detectable, till the time it becomes detectable. And if the patient is having a detectable PSA, we may just simply give the radiation therapy alone without the need of concurrent hormonal therapies. But if it is classified as high risk, then we have to go for an early or an adjuvant radiation therapy, which will help to reduce the 80% reduction in the metastasis. But if suppose the patient develops BCR, radiation will not be sufficient alone, and we have to add an intensification with androgen deprivation therapy to it. So the NCCN guidelines support the use of Decipher assay for the patients who are having a PSA persistence and recurrence after the prostatectomy as a category 2B recommendations. So coming to the treatment options that we have for the patients having biochemical recurrence, they are including the salvage radiation therapy, concurrent androgen deprivation with salvage radiation therapy, and the androgen deprivation therapy. So salvage radiation therapy has been found to be the clearest and also the best choice, which is providing the long-term freedom from progression. It has been seen that the patients who are having a PSA doubling time of less than 6 months, and and also patients who are starting it within the 2 years of the recurrence, they have almost threefold increase in within the disease specific survival. The normal dose that is to be given is at least 64 gray, which is given to the prostatic fossa with and without the base of the seminal vesicle, which depends upon the pathological stage of the radical prostatectomy. It has been seen that the whole body pelvis radiotherapy has been found to be better in terms of the biochemical progression free survival with respect to the prostatic bed radiotherapy, but although the overall survival has not found to be much beneficial. It has been also seen that the recent data shows that improved cancer control has been seen with higher doses of therapy with improved toxicity profile with advent of newer technologies of radiation therapy. Although what we find is sometimes there is a failure even after salvage radiation therapy, and that may be because of the persistence of local disease, because of the recurrence of the local disease, or because of a persistence of metastasis, or there is a new development of a metastatic disease. So these were basically two landmark studies which were done. That was the RAVES and radical trials, which showed that which were assessing the salvage radiotherapy in post-radical prostatectomy patients with PSA levels exceeding 0.1 and 0.2, and they showed that there was a 5-year freedom from biochemical recurrence, and biochemical free survival rates were almost 88%. So what we find is that the PSA levels are always found to be prognostic for the biochemical recurrence, and it has been seen that almost more than 60% of the patients who are treated with the PSA levels before the PSA levels of more than 5 have a much better progression-free survival rate of almost around 80%, and will be able to achieve a much better undetectable PSA levels as well. Biochemical progression is now being established as a accepted surrogation marker for the prostate cancer recurrence. But what are more meaningful endpoints? They are including the overall survival, the disease-specific survival, and the metastatic disease presence. In spite of the different indications of the salvage radiotherapy, the wait and see strategy is remaining an option, particularly for patients who are having a life expectancy of less than 10 years and with the EAU low risk groups. So what is the role of concurrent androgen deprivation therapy and salvage radiotherapy? They are the ones which are helping us to sterilize the micrometastatic disease. They're shrinking the tumor burden, thereby making the salvage radiotherapy more amenable, and also potentially working with the synergy with radiation therapy for killing the remaining cancer cells which are present. The studies which were done showed that there is an overall survival benefit, that is by using the androgen deprivation therapy, particularly for patients who are having aggressive disease features like the pathological T3B and 4 and a higher IUSP grade of more than 4, which benefited from the addition of the androgen deprivation therapy. It is the pre-salvage radiotherapy PSA levels which have been found to be prognostic biomarker for the anti-androgen therapy treatments, particularly if a patient is having a PSA value of more than 0.6 and we then start with the salvage radiotherapy, then the hormonal outcomes are found to be better in terms of the overall survival with respect to if we start with the early SRT therapy with the PSA values of less than 0.6.
You have 1
so
minute
what we
left.
find here is the fact that men who are found to be having at a higher risk of progression, particularly with a PSA of more than 0.7 and a Gleason of more than 8, they are benefiting with SRT with a long-term therapy of ADT of at least 2 years. The ones which are at lower risk with the PSA values of less than 7 and Gleason score 8, the SRT can be combined with a short-term ADT, which is of 6 months. But it is the SRT alone which is suffice enough for patients who are having PSA values of less than 0.5 and a Gleason score of less than 8. So what about the target volume and the dose toxicity? As we have already discussed, the whole pelvic radiations are to be given and at least 64 is to be given. But EAU guidelines are suggesting that up to 72 grays without PET-CT can be recommended with an acceptable level of toxicity. But although with an acceptable level of toxicity. So now what I'm talking about is the salvage radiotherapy with the PET-CT. So actually with the advent of PSMA PET-CT, they have changed the management intent in almost about 62% of patients as compared to the conventional staging. What they have done is they have helped us to find out many patients whose site of disease recurrence were not known, and they have helped us to find out the significant number of patients who are having metastatic disease. Those patients who are having negative findings of the PSMA PET scans or found to have recurrences confined to the prostate itself are high responders to the salvage radiotherapy with respect to those patients who are having positive nodes or distant disease found within the PSMA PET scan, and they have been seen to be having lower response with the salvage radiotherapy. So
Anand,
what has
I
been
think
the
I need to
impact?
stop you there, Anand. You are much beyond your time. If you have
So
one or two slides
just
to
2-3
summarize, yes.
Yes, I'm just summarizing. There have been the other advents as well, which is including the salvage lymph node dissections and the stereotactic ablation radiotherapy, which have been particularly used for patients who are having relapsing after the local treatment, particularly node positive and a highly selected M1 patients. So just a few things about the salvage lymph node dissections. It has been seen to be giving worse outcomes on long term with respect to the short term studies, although we need further trials on salvage lymph node dissections. There was a conference that was held in Dubai in ISIU 2021 who discussed about the role of this salvage lymph node dissections, and they found that it is actually helping in delaying the systemic treatments and prevention of local complications, but have to be done in patients who are having pelvic location with lower number of metastasis and low PSA with this prior to the salvage lymph node dissections. Now, what are the recommendations of the EAU 2022 guidelines? They say that we have to offer an early salvage radiotherapy, which is to men who are having 2 consecutive rise in the PSA. A negative PSA PET scan should be not delaying the salvage radiotherapy if it is otherwise indicated. We should not wait for the PSA threshold before starting the treatment. Once the decision of SRT has been made, an SRT should be given as soon as possible. And we may offer the hormonal therapy in addition to the SRT in men which are having with BCR. This is thus the summary of my whole slides, wherein we can just see that the biochemical recurrence can be defined as more than 0.2 nanograms per ml. And there are certain tools which are helping us, that is CAPRA and the clinical features. The diagnostic testings that we have already shown, that is the PSMA PET scans, choline, fluvicholine, and an MRI with the standard conventional technique as well as the biopsy. The newer techniques like the genomic decipher techniques which has come across, and then there are different therapeutic choices as well, which is salvage radiotherapy, androgen deprivation therapy, and experimental directions of salvage pelvic lymph node dissections, as well as the radiotherapy to the metastatic lesions. Thank you.
Anand, excellent presentation, but I think your best slides were the last few slides. I think you should have brought these slides much forward.
Exactly.
Anyway.
Thank you, sir.
Thank you. I don't know if maybe we can have one question, Dr. Himadri Pathak, please.
No, that's okay. I think it's a fabulous presentation. I think I don't have anything above this to ask him.
The next presenter, Dr. Piyush Patwari, he is going to speak on metastatic prostate cancer. Piyush, it's 7:50.
Yes,
You have exactly 20 minutes. Okay, try to be within the time so that we can have some question answers.
Sir, are my slides visible, sir?
Absolutely.
Absolutely.
Respected teachers, my topic for today's presentation is recent advances in metastatic prostate cancer. So about the staging has already been discussed in today's class, so I will not linger over it. Now I will discuss about the newer advances in the metastatic prostate cancer first, followed by the present guidelines and what are the treatment protocols to be followed these days. Now, first is the abiraterone acetate, which was FDA approved in April of 2010, following a landmark study, COU AA 301 trial, which showed overall survival of 15.8 months. Another study, COU AA 302 trial, which led to the better overall survival of 34 months, which led to the FDA to expand the label for abiraterone to encompass all patients with metastatic CRPC in 2018. Now, this was further confirmed by the Stampede on Latitude trial, which showed that the 3-year overall survival was 83% and 66% respectively. In another landmark study is going on, Peace 1 trial, phase 3 is going on, which has 4 arms, which was started in November of 2013, and patient accrual has completed in 2021, and the study will be expected to be completed in December of 2032. In the preliminary result, it has been shown that the patient given with docetaxel with abiraterone has better progression-free survival. Another drug of the same group is ornithorol, or a TAK 700, to current studies are going on, ELM PC5 and ELM PC4, and it is not yet FDA approved. Now coming on to the androgen receptor modulator drugs, the recent drugs are the enzalutamide, which is FDA approved in August of 2012 for the treatment of metastatic castrate-resistant prostate cancer following the AFFIRM trial, which showed a better overall survival and a progression-free survival. Another landmark study on the enzalutamide was a PREVAIL trial and the PROSPER trial, which led a PREVAIL trial showed there is a 29% absolute risk of death, and FDA expanded its label to metastatic prostate cancer regardless of whether they have received the prior docetaxel. And after PROSPER trial results came in, the FDA has further expanded the label into July 2018 to include any patient with castrate-resistant prostate cancer regardless of whether they have radiographic metastasis identified or not. Another drug in the same group is apalutamide, which following Spartan trial led to the FDA approval in February of 2018 for a non-metastatic castrate-resistant prostate cancer. But EAU guidelines suggest that it can be given in a metastatic prostate cancer also, with a strong support of evidence. Now coming, another study, Titan study was also given, also showed the 2-year survival with apalutamide is 84%. As compared to 74% with the placebo. Now, another recent upcoming thing is androgen receptor splice variant or ARV7 in circulating tumor cells. If this is positive for any metastatic castrate-resistant prostate cancer, that means that they will respond more favorably to taxane agent, while if it is negative, that shows that they will benefit equally from androgen receptor agents or taxanes equally. There is no more predisposition to taxane agent. Now coming on to the carboxytaxel, it is only shows the activity in the docetaxel resistant cancer. So it led to the FDA approval in June of 2010 as a second line treatment in a docetaxel refractory metastatic carcinoma prostate. And FDA modified further studies were done for the dose of the carboxytaxel, which showed that the lower dose of 20 milligram per meter square is equally effective. So now the recommended dose is 20 milligram per meter square. These are the few studies which showed the benefit of the carboxytaxel, like TROPHIX trial and CARD trial. Coming on to the immune therapy, GVAX and Prostavac are the few recombinant vaccine which are for which the trials are currently going on. Few tumor-associated antigens like PSMA, PAP, PSA. Here the trials are going on to develop vaccine against them. Now coming on to the immune checkpoint blockade, these are the new things, include the CTLA-4 ipilimumab, but in phase 3 trial, they did not show any prolongation in survival, so they are not yet FDA approved. Now another drug is anti-PD-1 antibody or pembrolizumab, which was FDA approved in May of 2017 for patient with unresectable or metastatic microsatellite instability high or mismatch repair deficient solid tumors who have progressed on prior treatment and who have satisfactory alternate treatment options. So if patient has a MSH2, MSH6, MLH1 or PMS2 genes, that means that the pembrolizumab will have an action against them. Now, newer PD-1 antibody like nivolumab, pembrolizumab, atezolizumab trials are going on for them, but the results are not yet come. Now, coming on to the recent drug which are FDA approved are the PARP inhibitors like olaparib. They act as on the somatic homologous recombination repair gene deficiency. This is approved as a breakthrough therapy by the FDA in May 2020 for the metastatic carcinoma, castrate-resistant prostate cancer who have deleterious or suspected deleterious germline mutation for the HRR gene like BRCA1, 2 or ATM gene. But they are not yet properly FDA approved, but as a breakthrough therapy, they are now approved, even by the EAU also. This is the landmark study, profound trial on the olaparib, which showed the progression-free increase in the progression-free survival of 7.39 months versus and overall survival benefit of 19 months. These are given in the patient who are previously treated with both docetaxel and at least one androgen receptor targeted agents. Now, the few rucaparib is another drug of the same category, where it is also partially approved by the FDA, but the confirmatory Triton trial is currently going on. Now, these are the few trials for the PARP inhibitors which are presently going on. Now, coming on the PSMA-based therapy, which my friend has already talked about. So PSMA can be used for the diagnostics also, and it can be used as a targeted therapy for the therapeutics also. That's why the term theranostics has come on. Here, the lutetium-177 molecule has been attached to the PSMA to target the tumor cells. It is also approved, and it has also come in the EAU guideline also. So these are the two study therapy where it shows the PSA reduction of more than 50% post treatment with lutetium-177 PSMA. Now these are the summary. First, I will talk about the summary for the metastatic hormone-sensitive prostate cancer. The recently approved drugs are abiraterone and enzalutamide, while few drugs which are awaiting further investigations are darolutamide, capivasertib, niraparib, and ortirinol. Now, metastatic castration-resistant prostate cancer. Recent approved drugs are olaparib and rucaparib as a PRP inhibitors and lutetium-177 PSMA agent. And ongoing investigations are for other PRP inhibitors, cabozantinib as a first-line therapy, nivolumab or atezolizumab. Now, coming on to the present guidelines at the what is the treatment for the metastatic hormone-sensitive prostate cancer. First line is a hormonal treatment. Primary androgen deprivation therapy is the standard of care for over more than 50 years. Now, there is a continuous debate over intermittent versus continuous androgen deprivation therapy, which is inconclusive till now. And some studies suggest for early versus deferred androgen deprivation therapy, where it is proven that early start is recommended. And deferred treatment can be for those patients who are asymptomatic and with a strong wish to avoid a treatment-related side effects. Now, combination therapies are always given with ADT. So, other options with us for the hormone-sensitive cancers are androgen deprivation therapy with immediate docetaxel, or abiraterone acetate, or enzalutamide, or a radiotherapy. Now, these are the EAU recommendation for the 2022, which shows that even for asymptomatic patient, we have to offer early systematic therapy even if the patient is asymptomatic, and we should not offer androgen receptor monotherapy for a patient with a metastatic disease. We always add some other drug with it. Now, coming on the treatment of metastatic castration-resistant prostate cancer, the first-line therapies are androgen deprivation therapy with docetaxel or abiraterone, or enzalutamide, or a vaccine in the form of Spilucel T or ipatercept. Now, the second line, if the patient has received docetaxel as a first-line agent, then we can, after in the second line, we can add cabazitaxel or abiraterone, enzalutamide, or radium-223 can also be used. Now, if after docetaxel and one androgen receptor therapeutic agents have failed, then we can add cabazitaxel, which has the best supported data. Other drugs which radium can be added. Now, the newer drugs like PRP inhibitors like olaparib and rucaparib can be added to it, or we can also go for lutetium-117 PSMA molecule. Now, the alternate options, what are the other options we have for the metastatic castration-resistant prostate cancer? Either we can have a first line of an androgen receptor therapeutic agent followed by docetaxel, or docetaxel followed by androgen receptor targeted agents, and a third line by PRP inhibitors if patient has progression. So the docetaxel before or after androgen receptor agents, patient can go in for any of these depending on the patient preference and the fitness for the agents. The other options are first line androgen receptor agents followed by docetaxel or cabazitaxel, and patient can. We have also an option of docetaxel re-challenge, but docetaxel seems to be less effective than androgen receptor therapeutic agents as a second line drug. Another option is androgen receptor therapeutic agents followed by another androgen receptor therapeutic agents. for a patient who are chemo unfit, but these are not much recommended because there is a cross resistance between other androgen receptor agents like enzalutamide and abiraterone. And patient can also have option of androgen receptor targeted agent followed by PRP inhibitors also. Now these are the EAU guideline, which shows that the first line treatment for metastatic carcinoma prostate castration resistant prostate cancer will be influenced by the treatment were used when metastatic cancer was first discovered. Also, for all CRPC patient, we have to offer molecular testing or germline molecular testing as well as testing for mismatch repair deficiency or microsatellite instability so that we can, if patient progresses, so other options will be available to us. So these are the recent guidelines which shows that the newer agents like PRP inhibitors and lutetium has been included in the guidelines. Thank you.
Thank you very much, Piyush.
Yes.
I request the teachers to ask questions to Piyush because we have a few minutes time.
Thank you, Piyush. That was a very crisp presentation. In metastatic sensitive hormone, hormone sensitive metastatic carcinoma, low volume disease, could you kindly elaborate the role of prophylactic radiotherapy to the prostate? What are our understanding about the situation? Along with ADT plus prophylactic radiotherapy.
So radiotherapy can be given as a first line
low volume
for the low volume disease with especially if there is a oligometastasis, so we can go for a ADT with radiotherapy for the patient.
Okay. Thank you.
Piyush, can I ask one question, Gopal?
Yes, please.
Yes,
Yeah.
please.
What is your line of management for visceral metastasis in CA prostate?
Sir, I will go for androgen deprivation therapy with docetaxel as a first line, sir.
Yes.
And if the patient progresses on that, then secondly, I will go for abiraterone acetate, and then and after that, if the patient is still progresses and if a patient is suitable for PRP inhibitors, then I will go for it.
Patient who is already on abiraterone, what will you proceed? How will you proceed? Already on abiraterone, and he has developed visceral mets after 3 years of radical prostate. A few lymphatic mets also, but our concern is mainly visceral mets. How will you approach?
So my next line will be, sir, chemotherapy, docetaxel, sir.
Docetaxel. Any second line chemotherapy do you have in mind?
So carbazitaxel can be.
Carbazitaxel. Good.
Carbazitaxel if patient is.
Okay. Well said. Thank you.
Before we move on, I have one last question to Piyush. I am just presenting you a clinical scenario. Your patient is a metastatic carcinoma prostate who has come to you with severe pain in his left femur. How are you going to manage this patient?
If the patient has a so that we have to suspect it is a case of a metastatic disease to the femur, for the left femur. So
Okay.
we'll start for the androgen deprivation therapy, followed by our radiotherapy to the affected for the. We will go for the radiotherapy to the affected sites for the as a palliation for the pain, and along with it we can go for other molecules like.
Look, when the examiner asks you how are you going to manage the case, management means investigations and treatment. So you need to first of all investigate what is the reason for the pain in the femur. So you need to mention that first before you actually tell me the treatment options. So how are you going to investigate this patient who is complaining of severe pain in his left femur in a case of metastatic carcinoma of prostate?
Sir, to diagnose it as a since he's also already a known case of metastatic CA prostate, maybe he has progressed. So I will go for a bone scan to diagnose the presence of any skeletal metastasis is present or not. And if the bone scan is come positive, then I will go for the management of the patient, sir, for the treatment of the.
Okay. Well, since time is short, I think I'll just summarize. You need to do a bone scan. You need to do an X-ray of the local area to look for any potential fracture. And if so, he may need an orthopedic referral. And after that, you will need to manage. You may even need to fix the bone. And if not, then you may radiate the bone. So your investigations will include local imaging in the form of X-ray, maybe an MRI of that place, and a bone scan.
Dr. Gopal, is there any role of PSMA PET to establish the diagnosis in such case?
No, I mean, I think the recommendation is to do a bone scan first.
Yes.
Not a PSMA PET scan.
But bone scan can be non-specific too.
Even fractures can give false.
Exactly. Yes, that's
Yes, it can be non-specific too. Anyway, this is a point which can be considered, because clinically, if you have any doubt to establish whether that is a cancer prostate or not, the last weapon in our hand is definitely PSMA PET scan to establish that it is definitely due to cancer prostate mets.
That's right. Yes.
That is the last weapon.
Our next topic is by Dr. Tarun Jindal, who is going to speak about the different techniques of prostate biopsy. I would request Ruma to please play his presentation.
Okay, sir. Sir, is it visible?
No, we can see the main screen.
1 second.
We need to play the video. In that case, shall we go over to Dr. Himadri
second.
Pathak's presentation and come back to you?
1 second, 1 second. Sir, is it visible?
Not yet. You have shared your screen. If you
Yeah.
could play the video, I think that will be fine. Never mind. I think we will go over to Dr. Himadri Pathak's presentation and come back to you.
Okay, sir. Let me check.
Can we start, please?
Yeah, Himadri, please start.
Yeah, just a minute. Okay. A very good evening to you all. Okay. Okay. Start here. Stop. Go back, please. Start again. Okay. A very good evening to you all. Here I'm to present the radical retropubic prostatectomy, a detailed description of the surgical technique. Now, detailed description of this surgical technique. Here is a stop. Here is a brief resume of the anatomy that is relevant to the surgical procedure. Here is a schematic diagram of the interrelationship between the prostate, the bladder, the ductus deferens, the ureter, the seminal vesicle, and the rectum. The dorsal vein of the dorsal vein leaves the penis under the buccal penile fascia, pierces the urogenital diaphragm, and trifurcates into a superficial branch which runs on the anterior surface of the prostate up to the bladder neck, and two lateral branches which embrace the side of the penis of the prostate up to the prostatevesical junction and ultimately drain into the inferior vesical veins. The nerve supply, the autonomic nerve supply, is for the cavernous nerves which run in a groove in the posterolateral aspect of the prostate. This nerve originates from the pelvic plexus, which is essentially a mesh of network on the lateral surface of the rectum in such a manner that the center of the pelvic plexus lies at the level of the tip of the seminal vesicle. The arterial supply comes from the inferior vesical artery, and as it progresses forward, it branches into a branch to the bladder neck and continues on as the capsular branch and the posterolateral groove. The capsular branch, along with the cavernous nerve, they constitute what is known as the neurovascular bundle. The sphincter forms an annular tubular structure around the membranous urethra and at the apex of the prostate. The prostate is invested by three fascia: the levator fascia, the prostatic fascia, and the denon-villus fascia. The prostatic fascia, it encloses the entire gland of the prostate. The levator fascia, it covers the anterolateral aspect of the prostate and is reflected onto the lateral pelvic wall. And the denon-villus fascia, which is not shown here in this, it runs between the rectum and the prostate, covering the posterior surface of the prostate. Here you have the resume of it. The dorsal vein, it pierces the striated urethral sphincter. The superficial branch of the dorsal vein, it runs over the levator fascia. The lateral branches of the dorsal vein, it runs within the prostatic fascia, and the neurovascular bundle, it runs between the levator fascia and the prostatic fascia in a posterolateral groove. Cross-sectional anatomy at the level of the apex and the base reveals that. At the apex, you can see that the neurovascular bundle is outside the sphincter, and it is between the denon-villus fascia and the levator fascia. At the base, again, you can see that the neurovascular bundle is between the levator fascia and denon-villus fascia, and outside the prostatic fascia. A well-performed radical prostatectomy must have the prostatic fascia in its specimen. With this brief anatomy in mind, here we shall progress on to the surgery. How do you proceed? Here is a brief of the instruments that we need for the surgery: a fiber optic headlight, a Balfour retractor, right angle clamps, scissor, and lots of clips. The incision is a midline infraumbilical extraperitoneal incision. In order to gain greater access into the retropubic space, sometimes the lower end of the rectus muscle is shaved off the symphysis pubis. Midline incision that is extended downwards. And the retropubic space is created by blunt dissection with the finger in order to mobilize the bladder off the lateral pelvic wall at this stage. In order to gain greater experience, the medial end of the rectus muscle is shaved off the symphysis pubis. And this is followed by placement of a self-retaining Balfour retractor. A Deva's retractor is placed superiorly and the bladder is retracted medially by another deverse retractor. The adventitia over the external iliac artery is divided. Tissues that are below it is made free. You can see that the cloacoids lymph node is identified, clipped, it is divided, and the dissection proceeds cranially in a reap and pluck manner. Ultimately, all the fatty tissues removed, the obturator nerve is skeletonized, care is taken not to damage the obturator vessels. This carries on up to the bifurcation of the common iliac artery, and this proceeds on into the pelvic floor on the anterior surface of the hypogastric vein. This completes the pelvic lymphadenectomy of these patients. This is followed by entry into the endopelvic fascia. The endopelvic fascia is entered on the lateral aspect, far away from the prostate gland. As you can see, as you progress distally, you can see branches of the internal pudendal artery, which needs to be clipped and ligated, and the superficial prostate portion of the puboprostatic ligaments needs to be divided. The Balfour retractor is placed now with the Balfour retractor giving superior traction after a pelvic lymphadenectomy, and all the fibrofatty tissue that is present on the anterior surface of the prostate is removed. And this fibrofatty, you can see the superficial part of the dorsal vein, which is coagulated, electrocoagulated, and divided, electrocoagulated. On the right side, the endopelvic fascia, on the left side, is entered, and there, right distally, you can see the branches of the internal branch, the pudendal artery, which is clipped and divided, just clipped and divided. The superficial portion of the puboprostatic ligament is divided at this stage, with a similar procedure is carried on the opposite side. You can see that the pudendal vessels, branches of the pudendal vessels is clipped, ligated, and the divided. The endopelvic fascia is entered, and the superficial portion of the puboprostatic. At this stage, a finger is introduced on the lateral aspect of the prostate, dividing the levator prostati from the prostate on either side. Traction is given by, and ultimately at this stage. Now, one must be quite aware of this entity called the accessory pudendal artery, which is present in 4% of the patients, and it is bilateral in 1.6% of the patients. You have to know this condition because this can cause some troublesome bleeding if this condition is not identified. Here, the right side of the endopelvic fascia is entered, and you can see a thick accessory pudendal artery that is running on the anterolateral aspect of the gland. This artery is looped. It is looped. And then ultimately, the numerous veins that accompany this artery is identified, and it is clipped. This maneuver is absolutely necessary, otherwise it would cause some troublesome bleeding at this stage of the operation. At this stage, it's clipped and ligated. A similar vessel on the opposite side is looped, and at the right angle, you can just tease this artery off the main prostatic tissue, and the individual corresponding branches are clipped and ligated. Clipped. Now we come to the control of the dorsal vein. This is a very important that the surgeon at this moment of time is facing the head end of the patient, he's facing the anesthetist, and the instruments of the surgeon will move embracing the symphysis pubis. The suture that is used is a 3/0 monocryl on a 5/8 circle needle, and the deeper portion of the puboprostatic ligament, the suture is underrun there. And the suture returns back taking care of into the periosteum of the symphysis pubis. The dorsal vein complex is divided. And this is a very important demonstration of an anatomy that as the neurovascular proceeds distally, near the apex of the, it is tethered to the apex of the prostate by an apical vessel. This has important surgical consequences. First, at the division of the external sphincter, and secondly, at the preservation of the neurovascular bundle, which I shall be describing later. After that, proceed on. Here is the suture that is passing through the deeper portion of the puboprostatic ligament and also the pubourethral component of the dorsal vein. So suture returns back to the periosteum. This procedure is again repeated. This procedure is again repeated, creating a horizontal mattress suture. Horizontal mattress suture. And the suture is ligated. It's ligated. And the dorsal vein is divided, giving that down traction to the prostate and the bladder. At this moment of time, bleeding from the proximal end is just controlled by simple pressure. And the dorsal vein is divided. As the division of the dorsal vein continues, you can see that the urethra is exposed. The urethra is exposed. The central portion of the urethra sphincter. The striated urethral sphincter is divided at its midpoint, not at the apex because of the apical vessel that keeps tethering onto that. Divided at the midpoint, and the space is created. Bleeding that takes place from the margin of the sphincter is controlled with clips. It's controlled with clips of them. And any additional bleeding that comes from the dorsal vein is suture ligated. So you have the smooth muscles, that is the suture ligated. So you have the smooth muscles of the urethra in the central and the sphincter on the either side of it. The proximal dorsal vein is soon in a running 2-0 vical suture in a V-shaped manner, the proximal. At this moment of time, it is absolutely necessary that you take perfect hemostasis of the field before you progress on to for a next step. Before you progress on to is in a V-shaped manner, continuous interlocking suture. Continuous interlocking suture. Once this is done, the urethra is divided and the urethral sutures. A right angle is placed beneath the urethra. This can take place at the apex of the prostate. Okay. And the urethral sutures are placed. Here's the right angle that is placed on the urethra. Anterior 2/3 of the urethra is divided. Anterior 2/3 of the urethra is divided. And once this is done, traction is applied into bladder neck, prostate, and sutures is placed at the 12 o'clock. This is let's say 2 o'clock inside out. Monocryl 30 on 5/8 circle needle. 11 o'clock outside in. 7 o'clock outside in. And 5 o'clock inside out. Once these 5 sutures are placed, the urethral catheter is removed. The urethral catheter is removed. And all these sutures are placed in perfect alignment on the body surface, and they're tucked away with the towel. they're tucked away with a towel so that in order to maintain this alignment in position. And after this is done, a 6 o'clock suture is placed and the posterior urethral plate is divided. And the posterior urethral plate is divided. After the posterior urethral plate is divided, the posterior striatus sphincter is divided at the mid-level of the division. And this is a right angle instituted between the anterior wall of the rectum and the posterior urethral sphincter from either side, so that the sphincter stays in the midline. It's insinuated between on a plane is created on the anterior wall of the rectum and separating this, and this is divided. And once this is divided, we come to the tackling of the neurovascular bundle. Here is the technique. There is no catheter. There's no catheter in the bladder. 1 minute. Can you freeze this, please? Can you go back a little bit? Just a little bit. Yeah. Here is the technique. There is no catheter in the bladder. With the sponge stick, the prostate is rolled over to one side, and at the prostatevesical junction, where the levator fascia is thickest, a right angle clamp is introduced, okay, and the tissue overlying is divided. This division continues along the margin of the prostate up to the midline. And at the midline, you encounter the apical branch of the neurovascular bundle, which is divided. Once that is divided, then in the midline, you now go down into a much deeper plane. You divide the denonvillous fascia in the midline, and then on the anterior surface of the rectum, you come back and you retrace your path. Here the apical branch is being clipped, and you retrace your path up to the midpoint of the prostate. This is how you preserve the neurovascular bundle. And if you have to delete if you have to sacrifice the neurovascular bundle, you take larger tissues, you move to the lateral surface of the rectum, move away from the prostate, and you carry on with your dissection. Here you can see that there is a catheter inside the prostate, but there is no traction that is being applied to that catheter. The right angle is introduced at the prostatevesical junction, and with the sponge stick, the prostate is rolled on one side. And the tissues are gradually freed, staying close to the prostate as possible with the direction towards the midline. As more and more tissues are being freed, the further and further medially. Once this is done, it is done in layers. Again, it is done in layers and proceeding again towards the midline. Now, as you proceed, you encounter an apical vessel here. And there you could see that there is the apical vessel there. And you can see that the neurovascular bundle that is being tethered by an apical vessel over here. Apical plane. This apical vessel is identified. You identify this apical vessel. You clip it. And you divide it. There is a corresponding vein with this, which is again identified. Just clip the stem on the specimen side. It has been clipped on it. It is divided to the small little amount of bleeding from the opposite side, and the other side it is also clipped. It is also clipped. Once this maneuver is done, now you are moving at a deeper plane. You are moving at a deeper plane in the midline. And this is where you are separating the entire tissue. We are going below the denonvillous fascia on the anterior surface of the rectum. The denonvillous fascia must come with the specimen. And there you have got the plane on a much deeper plane, and you are retracing your path. Retrace your path, ultimately you come to the midpoint of the prostate, the midpoint of the prostate. This is how you free the neurovascular bundles on either side. This. You proceed and ultimately stay as close as possible to the prostate, and more the prostate is freed, the more it is rolled over to the opposite side. More. And this is freed up to the midpoint of the prostate. Now, once this is done, you are coming to the opposite side. In the opposite side, you are going to sacrifice the neurovascular bundle. And this is why you take larger bouts of tissue. Here is the midline, that is the midline, that is the midline. And on opposite side, you are moving into a tissue that is between the rectum and all the tissue above it. You have to be very careful. The rectum, and you take larger chunks of tissue and moving away, staying far from the prostate, and you divide all the tissue that is anterior to it. That is taking care of all the vessels with it. The larger chunks of tissue up to the right angle is passed up to the lateral pelvic wall. Tissues are divided. The tissues are divided, and you are moving on the lateral surface of the rectum now. You're moving on the lateral surface of the rectum and coming back up to the midpoint of the prostate. And as you are moving further and further up, the prostate is getting more and more free. So on the left side, you have spared the neurovascular vascular disc. In the right side, you're sacrificing the neurovascular bundle. And indications for sacrificing the neurovascular bundle is number one, if there's an induration on the neurovascular bundle, and if any attempt at trying to free the neurovascular bundle, if you see there is fixity, then you have to sacrifice the neurovascular bundle. And once this is done, you come to the next step of the operation. You are freeing the adenovenous fascia, which comes with the prostate, and taking care that you do not injure the rectum. You do not injure. Now we come at the division of the bladder neck. At this stage, you reintroduce the catheter inside the bladder. With that, you give a superior traction on the catheter. Now the posterior branches become visible of the neurovascular become, you clip that. And once that is clipped, the lateral branches become visible. They are clipped. The anterior bladder neck is incised. Okay. The lateral bladder neck is divided, and ultimately the posterior bladder neck is divided, and ultimately the vas and the seminal vessel. So, freeing the neurovascular bundles on both sides, now the catheter is reintroduced. Catheter is reintroduced. Once the catheter is reintroduced into the prostate, okay, superior traction is given. You give superior traction on the prostate, and with the sponge stick, you can further evert the bladder. And now you can see a posterior vessel over here, which is posterior vessel from the neurovascular, which is tethering the prostate. It is divided, clipped, divided. It is clipped, and it is divided. Then you come to the lateral pedicle. Once that is done, as the bladder is being more dissection is carried out, and now you come to the lateral pedicle. Here the lateral pedicle is divided in layers. It is not clipped at this moment of time, and individual vessels are clipped on. It is divided in layers. They are divided in layers, and the individual vessels are clipped. They are clipped. They're taken with the help of a clip to take care of the individual vessels. Similarly, on the opposite side, the posterior vessel is tackled. Posterior vessel is tackled. And then after that, the posterior vessel is tackled, the lateral pedicle is tackled in a similar manner that we did on the opposite side. It's divided and then in layers, and then it is clipped individually. Now with further upward traction of the prostate, now here at this stage, you can see the base of the seminal vesicle on the left side. Now focus is turned to the anterior surface of the prostate. The bladder is opened at the prostatevesical junction. Here you are opening the bladder at the prostatevesical junction, okay? And a plane is created between the musculature of the bladder and the mucosa of the bladder at the prostatevesical junction. The bladder is open, and the plane between the musculature of the bladder is carried on along circumferentially around the prostate up to the lateral pedicle, up to the side. Individual vessels are clipped. And this is extended circumferentially around the prostate up to the lateral pedicle. It's clipped. Similar process takes place on the opposite side. Similar procedure is taking place in the opposite side. Plane between the musculature of the bladder and the mucous membrane, taking it down to the lateral pedicle. Individual vessels are clipped and divided. You're carrying it towards the opposite side. Once this procedure is done, the anterior bladder wall is open. Once this is done, the anterior bladder wall is open. The Foley's catheter balloon is burst, and the Foley's catheter is delivered into the womb. The Foley's catheter is burst, and the Foley's catheter is delivered into the womb. Now the posterior wall of the bladder is dissected. After a plane is created between the seminal vesicle and the vas, taking care at this moment of time you do not injure the urinary orifices, which is so well seen in this dissection. And at this moment of time, once the posterior wall of the bladder is dissected, a Babcock, we take a Babcock and it holds the posterior wall in the midline, and it is superior traction is given. Now you can see the two vas on either side, that's seminal vesicles laterally, and individual vessels that keep coming on the way, they're clipped and they are ligated at this stage. Individual vessels are clipped. The seminal vesicle on the left side is generally pulled into the wound, and as it is being pulled into the wound, individual strands which keep holding it back is ultimately ligated. In this presentation, you can see that the seminal vesicle is essentially removed piecemeal. Individual vessels, taken care of. Seminal vesicle is pulled into the wound, and clips are applied to free the seminal vesicle. Clips are applied, free the the differential artery it is divided and the specimen is delivered. This is the specimen. After the specimen is delivered, now we go in for reconstruction of suture. Once the intrasusceptions, continence, neck. The sutures are reapplied on the bladder neck, and the anastomosis is completed.
Excellent.
Here
Excellent.
is this thing. You're closing the bladder neck with a 2 ovicular. Some give interrupter suture. This presentation, you can see continuous suture. You have to be very careful. You don't take the ureteric orifice. You do not take the ureteric orifice in the suture. And the bladder neck is closed until you allow the tip of your index finger, if you allow your index finger to have an adequate lumen at the newly reconstituted bladder neck at the suture. Once this step is complete, now evert the mucosal suture. 4 sutures to evert the mucosal. You can do it with a 3 or 4 catgut. This is at the 12 o'clock position, 12 o'clock position, the 3 o'clock position, or rather 9 o'clock you would call it. That's the 3 o'clock position. And finally, the 6 o'clock position, which is essentially kept long. The 6 o'clock is essentially kept very long. And you can see with water is introduced and there's complete, the water is being ejected out over there. At this stage, you introduce what is known as the intrasusception sutures, which is essentially trying to maintain continence at the level of bladder. This is a very simple suture. The 2 sides of the bladder musculature is approximated in the midline on either side of the newly reconstructed bladder neck. It's a very, very simple procedure. Interrupts the sutures on either side of the musculature of the bladder that is approximated in the midline on either side of the newly reconstructed bladder neck. Now, once this is done, and you can see that water will be introduced, the water that is being introduced into, but there's no reflux, it's not refluxing out of the wound. Absolutely. So with this procedure, now we will go in for placement of the corresponding placement of the bladder neck sutures. The bladder is emptied. Now a Foley's catheter, 18 French all silicon catheter is introduced per urethra. This one. Yeah.
Himadri, little faster.
Yeah, I will. I'm almost finished. I'm almost done. The corresponding sutures, they are applied. The corresponding sutures, they're placed on the bladder neck. Those that were going from outside in, now they're coming out inside out. And once these sutures are placed, inside out. Once these sutures, the urethral catheter in proper alignment so that 3 sutures are on the left side and 3 sutures are on the right side. It's checked, hemostasis is checked, and the catheter is now reintroduced into the bladder, introduced into the bladder. After introduced into the balloon is inflated, the retractors are removed, the bladder is approximated towards the urethral sutures, and all the sutures are hand tied. hand tied in sequence. At the completion of, you have to see that you have to see that the catheter is playing freely and there is minimal extravasation. Finish. And now with that, finally, we close the wound. Thank you very much for your patient hearing. That would complete the procedure of an open retroperitoneal radical prostatectomy.
Thank you very much, Dr. Pathak, Madrida.
Thank you.
I think since Dr. Tarun Jindal is not available tonight, I think we will reserve his presentation and do it tomorrow morning during the continuing session on carcinoma of prostate. And we will, and also to be able to finish on time by 9 o'clock, we will go on to the MCQ session tonight so that we finish on time. Tomorrow morning, we will include Dr. Tarun Jindal's presentation. I would request all the PGTs today to be there tomorrow as well, so that you can participate in the continuing session on carcinoma of prostate. So, Ruma, could I please request you to present the MCQ questions for Dr. Pathak?
Okay.
Okay, sir.
Okay. Okay, very good evening. So here we are going to present the MCQ questions on prostate cancer. The first question, it goes that in a patient with T1 prostate cancer and survival expectancy over 10 years, radical prostatectomy, A, provides cure, improves quality of life, C, increases the survival rate, reduces the risks of metastasis, C and D, B and C. This is question number 1.
So it is E, that is C and D.
C.
It is E, that is C and D.
C.
Ruma, please give the answer.
Can we have?
Yes.
Okay, it's C and D. Well done. Well done. Can we go on to the next question, please? Which therapeutic method of localized prostate cancer is more effective according to literature? Radical prostatectomy, radiation, radical external radiation, HDR brachytherapy, and low dose radiation brachytherapy.
So it is A, radical prostatectomy.
Okay. Okay. Can we have the answer, please? Okay, thank you very much. Question 3. The continuously increasing development of technology and know-how upon radical prostatectomy has led to reduction of immediate complications, reduction of long-term complications, reduction of intraoperative complications, better control of disease, all the above, or none of the above.
All of the above.
So it is E, all the above.
Okay. Well done. Well done. Question 4. Which of the following statement is false? Anastomotic urine leak is less likely in robotic assisted laparoscopic radical prostatectomy. B, checking for anastomotic leak tightness has no prognostic value. Number 3, fewer sutures in the anastomosis, the more the chances of leak. These B and C and E, all the above.
All the above, sir.
Okay. Fine. Question 5. Which finding from prostate biopsy is most useful to predict extraprostatic expansion of cancer? Degree of differentiation, number of positive biopsies, perineural invasion, all the above.
All the above.
Number of, okay, all the above. Question 6. Robotic radical prostatectomy gives better functional result than open radical prostatectomy, gives the same functional results as open radical prostatectomy, should be abandoned if as a procedure if it has very high costs, is the only technique that is allowed today to be used in all cases?
It is B, that is same functional
Same
results as
Yeah, that's right. Gives the same functional results as open. Results are the same. Which histological pathological findings from the radical prostatectomy specimen and predict the presence of latent metastatic disease? Positive surgical margin, seminal vesicle invasion, lymph node invasion, B and C, A and B. Which histological finding?
B and C.
Sir, it is A and B, sir. E. Oh,
It's B and C. Seminal vesicle and lymph node invasion. Of course, lymph nodes. The risk of lymph node metastasis in a patient with prostate cancer depends mainly on the age, stage, Gleason score, B and C.
B and
B
C.
and C. Because B and C.
Of course. During radical prostatectomy, this is question number 9. During radical prostatectomy, in order to achieve a better oncological result, the surgeon will proceed to prostate dissection following the intrafascial technique, interfascial technique first, intrafascial technique, extrafascial technique, posterior technique through the non-venous fascia. All the above techniques have the same oncological result.
Interfacial technique. A.
Inter. Extrafascial technique, that is
Extrafascial technique.
you are sacrificing the neurovascular bundle. Okay. Following radiation therapy, prostate biopsy has to be negative within 6 months, within 12 months, within 18 months, within 30 months, none of the above. This is for a radiation oncologist.
A.
Can we have the answer, please?
A, sir.
Within 30 months, within 30 months. This is the answer. Question 11. All the following are prognostic factors for radiotherapy salvage after radical prostatic, apart from PSA levels before radiation therapy, PSA doubling time less than 12 months, time until the occurrence of biochemical relapse less than 2 years, 2 to 3 years, and the patient's age. Prognostic factors for radiotherapy salvage after radical prostate, apart from.
So it is the patient's age, D.
The patient's age. Okay. Okay. Question 12. Risk factors for prostate cancer includes which one of the following? Castration before 40, black race, Asian race, young age. Which are the risk factors for prostate cancers?
So black race.
Yeah, absolutely. Of course. Question 13. Side effects of hormone treatment rarely include which one of the following? Hot flushes, loss of libido and potency, osteoporosis, myelosuppression.
So it's D, myelosuppression.
Myelosuppression.
Myelosuppression, yes, yes. Well done. Question 14. Which one of the following symptoms is rare in patients with progressive prostate cancer? It's rare in patients. Symptomatic anemia, urinary retention, sexual dysfunction, hematemesis. Okay,
So it's D, hematemesis.
yeah, hematemesis. Okay. Okay. And the final question: in metastatic prostate cancer, median survival is 18 months. Hormone therapy will produce response in around 70% of the men with bone metastasis. The median response duration of hormone therapy is 8 months. And chemotherapy is the most commonly used systemic treatment?
D, sir.
The chemotherapy found a response in around 70% of the bone. This is the response that we have got. Okay, thank you very much for your patient hearing and for this wonderful session that we have enjoyed. Over to Gopal. Please.
Thank you very much to Piyush, Priyanku, and to Anand for your
Wonderful,
presentations.
wonderful.
I would request you to be there tomorrow morning as well for the second session on carcinoma of prostate. And we will also have the presentation on the different techniques of prostate biopsy by Dr. Tarun Jindal. I hand over to Dr. Ranjan De to conclude the session.
Excellent session, Dr. Gopal. And I'm very, very impressed with the knowledge of the students. Their performance in today's presentation is excellent. I have noticed that they are very well read. I congratulate all three of them for the extensive expression that they have given on that subject, and their depth of knowledge has been well expressed during this presentation. I also thankful to our two very good conductor of the today's evening, Dr. R.K. Gopal Krishna and Dr. Himadri Pathak. Both of them are very known names in the East Zone, and their academic and the teaching quality is also very high, that you must have understood, and it will be very, very clear to you all on tomorrow's session. So for the tomorrow's session, I expect all of you to be present in time to start a very, very important subject. With this, I thank once again to Dr. Gopal and Dr. Himadri and say good night to all of you. Thank you.
Thank you. Thank you. Good night, everybody.
Good night. Good night.